Drug-eluting stents have been a blessing in the field of interventional cardiology. Nevertheless, the permanent cage, which prevents vessel remodeling, is a limitation.
Mostly, the vessel will come with a natural curvature. Once you implant a DS inside, it will more or less straighten that curvature. And this is unnatural. And we have seen this happening with almost all kinds of DS. These will cause, in the long run, some problem.
The problem at the later stage is that we see these events occurring with an event rate of 2 to 3% or 4% annually.
It's a problem of a late catch-up in terms of restenosis and further neo-arteriosclerosis. So I think the Achilles heel for the current generation DES is really the problem of late catch-up disease.
The device is characterized by the presence of so-called uncaging elements.
There is a coating that keeps the device at a certain diameter. When the coating gets reabsorbed, and it will take a certain amount of time, the structure can move and can expand according to the force given by the vessel wall.
So in other words, when you disengage and the vessel grows, depending on the needs of blood flow, increased perfusion, vasodynamics, this will allow also the vessel to do that, which is something that we have not seen before with any of the metallic stents.
As an interventional cardiologist, I think this is almost like the answer of all our questions.
The implantation is exactly the same as the implantation process of implanting a second-generation drug-eluting stent.
It does have the radial force that a normal DES have, and then basically it also has the same trackability, flexibility.
Interventionalists will be very familiar in the way to handle it in terms of implantation, sizing, and everything.
You see a sort of cyclic pulsatility between diastole and systole, again, which I have never seen or noticed with any other stent that is out there.
We know that the meta stents prevent vessel constriction and vessel dilatation. If the stent is not anymore fixed to a certain diameter, these physiologic processes can take place.
These will allow the vessel to regain some of its natural self-control, distensibility-wise, so that the long-term outcome and the symptom will probably be better. And this will allow the vessel to accommodate the new depth or thickness of this neo-intima and maintain the vessel lumen patency.
In this particular mechanistic study, the vessel area increases, the bioadaptor area increases, while the lumen area remains the same, unlike what we see with DES.
Now the vessel is no longer caged by a mesh. So the vessel will regain some of this tensibility, and this has been shown by in vitro and also animal models.
Looking at the initial safety results, the DynamX data for safety looks good.
Based on the IVUS, angiographic, and OCT findings, these results are very promising and may actually mitigate the problems of the annually occurring events that we see.
What I'm hoping for is that this device can address the issue of late catch-up restenosis. I think if it really has a promise of restoration of vessel motor function, positive remodeling, and it can translate to positive outcomes after 3 years, that's a clear winner for DynamX.
So I believe that these returning or regaining of the natural curvature or unstraightening of the stented segment will be beneficial for the patient as well as for the physician.
I strongly believe that due to the fundamental design changes of this device compared to what we currently have today, this device may address all the shortcomings.